Everyone. It's always a pleasure to come back to Gata and Friends. So today I'm going to talk about the grey areas of management in premalignant and malignant lesion of vocal cord. Now, I take it for granted that the august audience which is present over here, they have the fundamental understandings of how to manage a malignancy and a premalignant condition of vocal cords. So I'm going to go one step ahead and touch base upon the controversial areas or the grey areas of management in cases of pre-malignant and malignant condition, and what perplexes us and what mostly is the present consensus. So, you see, coming to the pre-malignant lesion, dysplasia is a histological diagnosis, and presence of abnormal maturation cell and disorderly growth from base upwards is called as a dysplasia. It is reported in almost 2 to 10 per 1 lakh population, and malignant transformation rate is about 14%. High grade lesion means higher malignant transformation. It is the commonly perceived notion, but that is not true because the behavior of pre-malignant lesions are extremely variable and varies from patient to patient. And the mean time to malignant transformation is close to 5 to 6 years in a patient. So why is it so perplexing? What are the gray areas actually? Firstly, the classification. You see, why do we classify a disease? We classify a disease so that we can clinically correlate with it, prognostically correlate. But there has always been a lot of confusion in this area. Yeah. There is a widely variable natural history of the disease. So it doesn't follow a fixed set pattern. There is a lot of pathological dilemma as to which one to brand, and there is a lot of inter-observation.
গ্লুকোজ দিয়ে রাখেন আর সারফেস লেশন না ফিটে যাতে কোনো সমস্যা না হয় এটার জন্য আর খুব বেশি প্রচুর পরিমাণে পানি খাবে আর হচ্ছে আপনার অ্যান্টিপাইরেটিক দিবেন ব্যথার জন্য দিতে পারে।
There has been different proposal and 4 editions of WHO classification. Finally, we came to squamous intraepithelial lesions in 2017.
Hyperkeratosis.
The Juglana classification, which was amended in 2014, described it as a 2-tier system. So earlier it was mild, moderate, severe carcinoma in situ and then malignancy. But now they mostly call it a low grade and a high grade. But is it foolproof? Still, we do not have a very clear answer because a classification is usually related to the prognosis. So we believe that a high grade will have, a worse pathological progression, but that is always not true in cases of a pre-malignant condition. So we are still a bit hazy in that area. Coming to the different treatment strategies, there are a lot of questions we need to answer in a surgeon's mind. But what adds to the confusion is the natural tendency of such lesions to partially or completely regress. So you find a disease, it may so happen that it might regress, it might stabilize without further progression, or it might progress to an invasive malignancy. And you don't have a magic wand to say that, okay, this particular disease is going to progress in this manner. The challenge of managing such laryngeal dysplasia, there is not a clear consensus. The reason is this, because we don't have a clear understanding yet. The challenge is to find a balance between achieving the oncological clearance and the acceptable functional outcome. So in the principle of management, it is now believed that all the single and multiple foci should be completely excised, widespread, or if there's a confluent leukoplakia, there can be different areas of different malignant transformation. So you need to take biopsy, punch biopsies from different areas and a rebiopsy if necessary, and then plan it properly at a second stage. It should be properly oriented.
আমাদের প্রথমে একবার নিলাম পরে সারাবার নিছি মাল্টিপল বায়োপসি নিয়ে লাগতে পারে মানে মাল্টিপল সাইট থেকে বা মাল্টিপল টাইম
You can observe or excise. Be very careful not to ablate because it might damage the underlying epithelium. Change in appearance is important to understand whether you need to excise or not, and voice should be taken into consideration. If there is a focal severe dysplasia, it is now considered or managed like a T1 laryngeal cancer. Very important to remember, and resection is what is recommended. So in widespread and severe dysplasia, again radiotherapy can be used. So you see mostly in cases of leukoplakias or early pre-malignant lesion, laser is the preferred modality used. Stripping is not advisable, neither is ablation because it leads to worsening of the vocal condition. Here you can see how we manage a leukoplakia, very precise incisions you have to take along the margin and gradually lift up the layer. It is always a subepithelial or a type 1 chordectomy majority of the times, because when you are going deeper, it means that it has already invaded. So you see, beautifully you can see the white glistening vocal ligament. This is what needs to be exposed. And very precisely, without causing buttonholing, punching or tearing, you have to take out the entire leukoplakic patch. And I usually don't use a continuous
কিসের ভিউ এটা এন্ডোস্কোপিক ভিউ
pulse or an alter pulse with a basic minimum wattage by which you can take it down. So gradually you work around the entire thing and take it out completely from the close to the anterior commissure region. Also you have to take it out. Be very careful not to touch the anterior commissure area. You need to preserve that mucosa, because if you damage it, there is chances of scarring which can be there and formation of webs at a later stage.
সাইলিস্টিক কিল দিয়ে দিবেন
So here again we go and finally we take down the entire thing. So now a very interesting aspect is the pathology, surgeon and inter-observer variation, this interplay. What goes wrong? There can be a sampling error, you are taking the specimen, you are not mounting it properly. There can be an analytical error from the part of the pathologist, or there can be an error in communication. Either you are not communicating properly or the pathologist is not. So it is always advisable, when there is a confusion, you involve two pathologists. Let both of them see the specimen and give a consensus decision on what it is. And histology should always be studied in context. For example, if there is a report of a severe dysplasia, follow-up shows a proliferation, you should have a very low threshold to do a biopsy. So this is very important aspect of the entire management. So good OT practices are important. How you should mount, you should take intraoperative photographs, procedure should be categorized according to ELS. The technique and extent of resection should be well documented and told to the pathologist. So these basic practices are important. Grossly, this is how we manage. Follow-up protocols are mostly taken up depending on high risk and low risk. Mild, moderate situations can be have a 6-month follow-up, but high risk with severe dysplasia, smoking, persistent hoarseness should have a shorter one. Coming to glottic carcinoma, there are different areas, gray areas, especially the treatment of early glottic, quality of voice, chordectomy, voice rehabilitation, post-irradiation situation, and anterior condition. Briefly, I'll touch base upon all this. You see, radiotherapy versus surgery has always been a tussle, but now we know that they have a similar survival advantage, almost a similar locoregional control. But for a T1A glottic cancer, now it is hands down, transoral laser surgery is recommended. Very interesting thing happened in UK, the Easter trial, which recruited population so that you can compare between the radiotherapy arm and the laser arm. They didn't find people to get randomized, because they said that I don't want to waste my 6 weeks time behind the radiation and get all the side effects and complications when I'm going to get the similar vocal outcome like a laser with a day surgery, and the survival rate and the results are going to be same. So now in this situation, it is definitely every ENT surgeon needs to understand and needs to practice this. In higher cases, there has not been, the vocal handicap index has not shown too much of a difference. You can even do an intravascular with a good voice outcome. It might take some time, but it is quite precise. This is T1 early lesion, you see how you take it out, give a proper margin all around, mount it, and then send to your pathologist for evaluation. Coming to involving anterior commission, this is a very tricky area, we all know. Now, anterior commission lesion, you can do a laser, you can do open partial anerectomy or a radiotherapy. To be very honest, there is not much of a difference in the survival advantage, and they are bound to recur. A certain percentage they recur. And radiotherapy has shown some advantage as far as the voice quality is concerned. So it is an individual preference in such situation. There's a lot we can talk about it, the entire day will pass off. But I'll just briefly skip upon and go to residual carcinoma. Now, for example, if there is a recurrence, issue is that if you do a laser, you can again redo a laser. But if you do a radiation, the laryngeal preservation rates are very, very less, practically nil. You cannot preserve a larynx when you give a radiation to a person. So, in very limited lesions or small lesions, you can actually like this, it got small recurrence. You can take it out with a laser with a good result. But beyond that, it is difficult, and you might have to. I have a series of cases where I have done a laser with good results, but it has to be well selected and precise. Coming to post-laser chordectomy voice rehabilitation, voice outcome or poor only when it is about type 4 laser chordectomy, when you reach up to the perichondrium. When you expose the perichondrium, it heals by fibrosis and then the fibrotic. So, like this is a case where 2 years after follow-up, you can see there's a persistent dysphonia. Anteriorly, there's a scarring, there is a new cord formation, there is fibrosis, there is clotting gap, as a result of which there is
anterior gap আছে তো phonatory gap.
So what we prefer to do
কেন ভয়েস তো anteriorly
medialization thyroplasty with the Gore-Tex.
ফোনেশনের জন্য তো anteriorly
posterior to respiratory. If you use a silastic, there is every chance it will recoil back because there is stiffening of the cord. The moment you try to push it, it is going to push you back. But Gore-Tex's advantage is that it creates the space and it can medialize. So this is how the marking is given very briefly. We drill out a hole in a specific position with a
horizontal
5 millimeter. Then we cut
5
the
millimeter by
Gore-Tex
14 millimeter
into 5 millimeter strips. As you can see, you mark it 5 millimeter. You get your Gore-Tex from your cardiothoracic CTVS colleagues. They use it routinely. So you create fine strips, and it is very important to create a bit of a space over there and bevel the margin so that it goes very easily. And that space that is created, there you layer by layer you insert the Gore-Tex. So
কি হলো এটা ওটা কি সুতা
গজের মতো শীত গজের মতো ওটা দিয়ে পুশ করে দিল
this is preoperatively, you can see how breathy the voice is. If you do a thyroplasty,
এই যে গ্যাপ থাকলে এরকম শব্দ
texture and the quality won't improve, but the glottic gap will close, so it will be understandable.
full voice.
Okay, can you speak 1 to 10 loudly?
1, 2, so there is increase in maximum formation time and amplitude because the glottic gap is closed, although the texture is a bit loose. But this really works in this kind of a tricky situation. So it's a vast subject and we can talk entire day on it. I tried to concise it and brief it.
There is a
so in all this chaos, there is still an order. The quest still continues. Thank you so much.
Thank you, Dr. Pandya, for that wonderful talk. We'll again have the discussion after the session, towards the end of the session. May I now invite Colonel Dr. Ali Azad for talking on a very special topic which we give very importance nowadays, that is quality of life. Balancing between surgical outcome and quality of life in advanced laryngeal cancer. Colonel Azad, please.